All right. Well, thank you everyone for joining. I know that there'll be others that will be joining as we get started on our kickoff program of the Collaborative and Health Equity Global Health Arm. I'm Dr. Anandita Deb, and I'm a neurologist here, an associate professor in neurology, and I'm the director of the Global Health Arm of our Collaborative and Health Equity. So I'm going to spend the next few minutes just giving you a little bit of an introduction to our Global Health Initiative and then some upcoming dates and events, and then we'll transition to Dr. Banke-Thomas around noon. So for those of you who might be joining the first time and haven't heard about our collaborative, it is fairly new, and I'm leading the Global Health Pillar. So this has a description of the vision of our Global Health Pillar, but to summarize, we're really trying to work with our schools, our regional campuses, and the universities in the local Worcester area to try to advance global health and health equity among our collaborative partnerships. So there's some of the things that we're working on are to improve our healthcare service, clinical work abroad, research, and education. And I know many faculty, staff, and others are involved in global health, many of our learners as well. So, part of our vision is to try to get everybody together, really create this global health community, and offer programming like we have today. So the mission of our collaborative and health equity is to nurture and sustain community embeddedness and trust, to center health equity through innovations in clinical care, research, education, local community, as well as global engagement, and to bolster community workforce development, participation in clinical trials, and underrepresented minorities in medicine. And our overall vision for the collaborative is to advance health equity for vulnerable, underserved, and historically marginalized communities. This is our collaborative team under the leadership of Dr. Krista Johnson-Agbakwu. We have a team of our group here that you can see. So Sarah Forrester is leading our research, education, and training arm. Cherise Hamlin is leading our URIM community workforce development and capacity building. Dominica Perona is our director of community engagement and outreach. And we have the amazing support of our program manager, Grutze Barluenga, and our program coordinator, Sammy Doxey. We really encourage you to sign up for our Global Health and Health Equity mailing list. So this is for our Collaborative and Health Equity mailing list. The links are all on the side here. And also you can follow us on Instagram and LinkedIn. Our mailing list questions are very simple. You just have a screenshot here, so it shouldn't take you only a few seconds to fill this out if you'd want to get more information about the work we're doing and any upcoming programming. And a couple of things that we're doing in terms of the global health arm of the Collaborative and Health Equity. So one is our Global Health Faculty Consortium. And under this faculty consortium, we have, as we know, as I mentioned, faculty in all of our schools and regional campuses who are interested in global health in terms of research, clinical, and education. So we're trying to bring everybody together under the umbrella of this consortium to meet, discuss opportunities, challenges, collaborations, and also work towards shared goals. One example being bilateral exchange programming. So we, at the request of our faculty who really want to transform the collaborations we have into bilateral exchanges, we have made some progress in trying to find out what is happening on the state level in terms of advocacy for this, which there is, and trying to get involved and get information on where this stands. So if you're interested, you want to, be involved, you want to join our consortium meetings, they're open to really anybody who's interested. The upcoming dates are listed below. The next meeting is actually tomorrow at 3 p.m. And then we're meeting up approximately every other month. So, even if you can make one of these, that's completely fine. We realize that people may or may not be able to attend all of them based on schedules. And to join our Collaborative's Global Health mailing list as well, this is a QR code that you can join. To the next slide, please, Sammy. Thank you. So for some save the dates, if you're wondering, okay, well, there's this talk by Dr. Banke-Thomas, who's going to kick us off in our first collaborative global health seminar series. We have another upcoming seminar with Dr. Sierra Washington, who is a clinical associate professor and director of global women's health at Stony Brook University. And we'll be hearing from her on the global health work that she is doing tentatively in March 2025. So we don't have a date fixed yet, but working on that. And as a member of the Consortium of Universities in Global Health, this is a reminder that there is their annual conference coming up in February on innovating and implementing in global health for a sustainable future. And then finally, we would love if you could all save the date for our first inaugural Global Health Symposium, which will be on April 29th, 2025. More information on that will be coming out, but we'll be sending out reminders and more information on the programming for that symposium. All right, so I am going to introduce Dr. Banke-Thomas in just a minute. I did want to just share that, this is a webinar format, and we would love if at the end of the talk, you can use the Q&A function to put in questions. We'll try to field as many questions as we can in the time that we have. And so please feel free to put your questions in there. Okay, so we have a few minutes, and I will start by introducing Dr. Banke-Thomas. So Dr. Aduragbemi Banke-Thomas is a physician and public health and health policy researcher. Presently, he's the Associate Professor of Maternal and Newborn Health at the London School of Hygiene and Tropical Medicine in the UK, where he's also the co-director of the Center for Maternal, Adolescent, Reproductive, and Child Health. He's a visiting professor at the University of Greenwich and on the Erasmus Mundus Europub Health Program. He's also a visiting research fellow at the London School of Economics and Political Science and Health Systems Research Lead at the Maternal Reproductive Health Research Collective in Nigeria and principal researcher at the Senghor Chair in Health and Development in Sub-Saharan Africa at the University of Ottawa in Canada. His scholarly work is focused on exploring issues on and strategies to optimize access, experience, and outcomes of maternal and newborn health and interventions and services in low and middle income countries, and he has had over 120 publications related to these themes. Presently, Dr. Banke-Thomas is the principal investigator for the Google-funded On Tackling In-Transit Delays for Mothers in Emergency, or On Time, project, and the Gates Foundation-funded Lagos Verbal Autopsy Social Autopsy project in Nigeria. He is also the co-lead for the London School of Hygiene and Tropical Medicine-led Research Excellence for Reframing and Accelerating Maternity Equality collaboration that was awarded £50 million to conduct innovative research in maternity inequalities in the UK. Dr. Banke-Thomas is the principal investigator for a number of cutting-edge research exploring issues of access, experience, and outcomes of care for pregnant women across diverse settings, and has received funding for research from the National Institute of Health, Gates Foundation, Google, and AXA Research Fund. He is also the co-investigator on a number of Gates Foundation-funded projects, including an implementation science project for intravenous versus oral iron for iron deficiency anemia in pregnant Nigerian women, postpartum women, and a hybrid trial on oral azithromycin used during childbirth to prevent severe maternal infection among Nigerian women giving birth vaginally. He is also on the editorial board of several journals. So I'm sure the accolades go on. He's very distinguished, and this is such an honor to be able to have Dr. Banke-Thomas join us to kick off our Collaborative and Health Equity Global Health Seminar series. I will stop here and pass it along to him to start his talk.
Thank you very much, Dr. Anidinta. Thank you so much. We really appreciate your kind introduction. I'm just going to pull up my slides now. Just make sure we've tested this already. So just make sure this is good. Do you have the full screen? Perfect. Okay. Thank you so much for that kind introduction, and sincere appreciation to my phenomenal colleague, friend and sister, Professor Krista Johnson Agbako, for inviting me to speak at this first Peers Global Health Seminar Series for the Collaborative in Health Equity at UMass Chan School. I'm really pained that she's not here. We've been talking about this for some time, but I hope she comes back soon, stronger and better. I'm sure the school knows that you got a real gem in recruiting Krista. And so big ups to you, Krista, and see you soon. I'm also super grateful for everyone who's been involved in organizing this. And Dita, thank you so much, and Maria, for keeping up. I really appreciate. And yes, super grateful to everyone who has made our time to listen, to join and listen to me, whether it's morning, afternoon, or evening, wherever you are. Really kind of you to join. But I must warn you, what I'm about to talk about is something I'm very passionate about, right? And so do not be surprised if at the end of the presentation I infect you with my passion and you all run along being a maternal health enthusiast also. So looking forward to our robust discussions. So I've titled this talk Urban Inequalities in Accessing Emergency Obstetric Care in the Global South. My hope is that over the next couple of minutes, and I think I have 45 minutes to speak, and then we have questions at the end, that I'll be able to share with you the state of play and what I think is needed for the future based on the available evidence out there. And I thought the right place to sort of start this conversation from is really from those who are involved in this, and that is the pregnant women themselves. If we can all agree on something fundamentally before we even go forward, is that it's only right for a woman to be pregnant and expect that at the end of that 9 months or thereabout time that she carries the baby, that she is fine, baby is fine, and everyone is happy. Can we all fundamentally agree that this is okay? Right. And if you can just do a thumbs up also in the chat, just make sure this is as interactive as possible. And that she gets pregnant, she's trying to just give life as a human, and that at the end of those 9 months, she's fine, baby is fine, and she can move on with her existence, move on with her livelihood, do exactly what she expects to do normally. However, unfortunately, that's not the case for many mothers. Um, Maternal mortality remains a huge problem in the global south. Um, in fact, the most recent estimates that we have from the World Health Organization is that 287,000, oh, have I gone past my 287,000 maternal deaths occurred in 2020 alone in 1 year. 287,000 women died while trying to give life themselves. And almost 2 million babies were born dead. 2 million, that's a lot of babies, and that's what we call stillbirths. 2 million babies were born dead. Now, the staggering reality is that the majority of these deaths, in fact, 99% of those maternal deaths that I just described a moment ago, occur in what we call the global south, so the low and middle income countries generally. And 97% of the stillbirths, those are those babies that are born dead, occur in the global south also. Now, this is the world as we know it, right? You can still find the United States where it is over there in the corner, Africa as a continent, with all the 54 plus countries that are part of Africa. And so this is how we know it. If we were to take some of the numbers of the maternal death and use those numbers to represent the area, the geographical space that some of these countries would look like, this is how the world would look like. The United States would be a strip of land, just somewhere in between separating the Atlantic Ocean and the Pacific Ocean. And Nigeria, and I did not declare my nationality, I should have done that at the beginning, that I'm Nigerian. And if you know where Nigeria is, I'll try to point that out. Here, that's Nigeria. the country was always, we call ourselves the giant. Well, we're allowed to call ourselves the giant of Africa for different reasons. But truly, based on those maternal mortality figures, Nigeria would then truly be the giant of Africa. Now, again, just staying on that theme of Nigeria, I do want to point to you the flag of Nigeria, and I'll tell you why this is important in a minute. Please just keep note of that. It's green, white, green. Okay, just take note of that as I move on with my presentation. Now we know how to prevent this maternal deaths. We know that if we can get women access to emergency obstetric care, which is a suite of services, a suite of interventions that are evidence-based, that if women can get access to such services, these are clinical services, some of them are surgical services, that we can reduce those maternal deaths by as much as 50%. And those stillbirths that I talked about earlier on, the 2 million plus, we can reduce as much as 75% of those stillbirths, if only we can get women access to emergency obstetric care. To date, a lot of efforts has been focused within the global community, has been in terms of how we work on reducing maternal mortality and stillbirths. I've mostly focused on ensuring that, EMOC is available. That's the service, emergency obstetric care, EMOC is available, trying to sort of minimize the financial barriers to care that that women may face. And more recently, trying to improve care quality when the woman gets to the facility. But the way this care is delivered means that the woman has to travel to a facility to get the care. Nobody does a cesarean section on the road, except, maybe the mother is about to die and this is last minute, let's salvage something. Every sort of emergency obstetric care intervention that we have is delivered in a health facility. So somehow we need to ensure that women are able to reach health facilities that can provide emergency obstetric care. And this is not all facilities. It's not every single facility that can provide the package of care that women need. And maybe it's even for some of them, they can provide, on some days, but then the MD, the medical doctor that can do some other services is not available at different times of the day. Unfortunately, and this is very important in the context of the sort of settings that we're describing here, is that many women are left on their own to travel in an emergency. You can call 999, 111, whatever number it is to come pick you up. Women are left to travel on their own, and they face immense challenges in reaching facilities that can provide emergency obstetric care. Okay, and here comes the challenge, why I think we need to sort of think differently. And so over the next couple of slides, I would walk us through the state of play on how we sort of look at this in between of how women get from their homes or lesser facilities to get to facilities with capacity to provide emergency obstetric care, and what the future looks like in this space. And I would like to talk about it through 4 different areas. One is to really characterize the problem. And you'll see when we go through this bit why I think it's very important for us to review what the problem really is. 2 is to look at the methods that we use to assess the scale of the problem. 3 is the solutions that have been put forward to address those problems and the new thinking needed with this. And 4 is that relates to the targets and the benchmarks that have been set. Okay, so let's start with the nature of the problem. I'm not sure how many people know this film, but Why Did Mrs. X Die? It was an animation that was done in 1988, produced by the World Health Organization. It was a short film, and it was really based on a lecture by the now late Professor Mahmoud Fatala, which was titled The Maternal Death Road. And the aim of that video then was to raise awareness on the myriad of women who were dying as a result of complications of pregnancy and childbirth. Several years after 1988, in 2016, there was an attempt to remake this video, and it was called Why Did Mrs. X Die? Retold. You would hope there were some changes from 1988 to 2016, but no, it was still the same. So let me quickly show you some screenshots from that animation. It started out with some health workers who were reviewing a death of a woman who died from complications of pregnancy and childbirth. The case note had been closed. It was agreed that this woman was died because of some complication that she had, and that was it. And then they went back to reviewing her history, and you'd see this woman, Mrs. X, was presented as a woman who lived in some rural community. You can see some thatched roofs over there. She was pregnant, obviously, and then she was walking down on her own, trying to make it to a hospital. Then she started bleeding, and then she was so poor, and then some people had to help her on a on a truck to take her to the hospital, and then she died. Important to sort of look at this context that this was pitched as a woman who was in a rural setting, who was very poor, who had minimal resources, and then she died. But I've always queried, like in my practice, in my clinical practice, I know that women, not only women from rural communities also die. There's been this strange perception that the women in the city, they are totally fine. They are, they are okay. They can get access to care when they need it. Their outcomes are totally fine. But those in the rural communities, those are the ones that have issues. And we've had this same perception of this problem way back from 1980 showed all the way to 2016. And I'm sure for many people, they still believe that this is the case even now. Um, but that's not the case. I know that pregnant women in the cities also die due to complications of pregnancy and childbirth. And the news media, when you look at these are news reports that I was able to pull up. This is Port Harcourt, a city in Nigeria, another woman from Port Harcourt who died in Nigeria. This is Kano, another big city. And just to make it clear that it's not just in Nigeria, I pull up this headline news from a report from Ghana also, which probed a death of a pregnant woman who died in Sontre. So these are all deaths that occurred in cities. So clearly the problem is not just rural areas. Maternal deaths also occur in cities, and it's important for us to sort of recognize this. Now, there's another issue going on the other side. There's another challenge that we are facing as a humanity, and that's this population increase. People are not dying as they used to die before. We know that there's a huge increase in population that we expect between 2022 and 2050, and a lot of this population increase is happening in cities. In fact, the available evidence shows that 950 million more people will be living in African cities by 2050. 950 million more people. Now, just to put this in context, we know that within the existing health system, many facilities are already overwhelmed with the cases that they're having to see. So, and those cities will now be having to welcome an additional 950 million people. How is care going to be provided for these lots that will be moving into cities? I've always made a joke that I think in the next couple of years, the rich people will live in the villages and the poor people will live in the cities if things continue the way they're going right now. Now, of all these cities, I'm not sure how many people on the call have visited this mega city. And that's the mega city called Lagos. Now, this is a city that I'm most familiar with. The city is such a small strip of land, but we are talking about a population that is about 26 million that live in Lagos. So it's certainly a good place to look at this problem to really get a sense of how women travel to care in this city. It's called Africa's model mega city. At night, it looks like every wonderful city, just like New York. All right, okay, every wonderful city. But then there is the eighth wonder of the world in Lagos, which you probably don't know yet, and that's Lagos traffic. If you've experienced it, I'm sure you know what I'm talking about. This can be very colossal, right? And I think for 1 minute, I just want us to think about the journey of a pregnant woman trying to navigate this colossal traffic that you see in Lagos, where 26 million people live, where motor vehicular transport is the main mode of transport. I know there are some, there's some light rail systems coming in right now, but this is how we move about in Lagos. Okay. Um, so just think about it for 1 minute, how a woman would navigate this in an emergency trying to make it to care. And there's another bit to also think about. There are those who live in the urban slums, who have to first of all come out from those slums, get onto the city roads to then make it to the facility. Now you recall that I showed that photo of Lagos at night. That's the part of the city that you see on the other side. Those in the slum live sometimes in areas like this. This is Makoko is in Lagos. And so again, think for 1 minute of how a woman living in the slum area would be trying to access care in an emergency. And I have a wider shot of that slum. Okay. So this is certainly a challenge in terms of how women in this area that live in the settings would need to be able to access care. Okay. And there is evidence to show that a lot of that urban population that I showed earlier, the increase that we'll be expecting, a lot of it is actually increasingly slum populations. So it was important for us to then, in doing our research, to really engage with women who live in cities to get a sense of how they reach services. How do they travel to reach services in an emergency? And that led to this work that we did, which is published in Reproductive Health, where we titled Reaching Health Facilities in Situations of Emergency. And this was a qualitative study trying to get a sense of experiences of women in Africa's largest city. I didn't want to bore you with some of the quotes, but what we did with the evidence that we gathered from this was to make an animation of it, building on what WHO had done before. Why did Mrs. X die? We said, well, Mrs. X also lives in the city. I would warn very quickly as I played this animation, it's about 4 minutes, that the themes that are going to be shared there is really just to give a sense of that experience, to help all of us on the call get a good grasp of how access to emergency obstetric care can look like. And it's certainly not meant to trigger anyone. So I'm going to hit play and hope this works like it did before.
There is a perception that only women living in rural areas have limited access to life-saving maternal health services, which places them at a higher risk of maternal death than those living in urban areas. Evidence from new research shows that for different reasons, women living in urban areas also experience difficult access to critical services, and in suburbs and slums have a higher chance of maternal death following pregnancy and childbirth complications. In many low-resource urban cities, traffic is an enormous challenge that many have to face to access services. Insecurity has also become rife, so much so that many consider it dangerous to commute by night. A couple living in the suburb were expecting their first baby soon, and everything seemed fine. One night while sleeping, the expectant mother started having a nagging headache and severe upper belly pain just below her ribs. She woke her husband up and with grunts said, "I need to go to the hospital now." She was struggling, but she and her husband agreed that it was better to endure it for the night and travel in the morning when it's safer. Then came 6 a.m. They set out for the hospital. But while on the move, she started experiencing some shortness of breath and blurry vision. Pregnant women living in urban slums, their experience in accessing care differs. 1 minute. 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 1 Travel to connect the big hospitals, many of which are far away from the slums, is sometimes difficult. But Jumoke was well aware of this. She registered with a small private clinic not too far from her house, but preferred it because people say it's good. One evening, she noticed she could not feel her baby move anymore and requested to be moved to the clinic. Upon arrival, she was received by a nurse on duty. After a quick initial assessment, the nurse concluded that it would be better to transfer her to a facility that could support the delivery of her newborn, and she was referred to a larger hospital. The nurses tried to organize the clinic ambulance. After some delays in preparation, the woman was finally on her way. Another young lady, Amina, who worked in the city's largest market, recently found out she was pregnant, having missed her period. While she was working with her sister, she suddenly noticed she was bleeding. She alerted her sister, who was hysterical when she saw blood. The sister had the young lady sit on a nearby bench while she went to hail a taxi. It took a couple minutes to get a taxi that would carry an emergency. But eventually, she found one. And they began their journey to the hospital. As they journeyed, they soon encountered heavy traffic on the road. Noticing Amina being so faint, the sister begged the driver to hurry up. Sadly, other commuters did not give way to them. For pregnant women, even in urban areas, some end up as near misses, some lose their babies, and some lose their lives. Reaching health facilities capable of providing the much-needed emergency obstetric care is truly a case of every second matters. Addressing barriers that delay access must be prioritized by all stakeholders if poor outcomes are to be minimized.
Right. I hope that video really helps helps all of us get a sense of that this challenge is not a rural problem, but it's also an urban problem that needs to be addressed. Those were all based on actual stories of women who actually experienced challenges in getting access to care in Lagos. There's a QR code that I've put here. If you want to watch that video, which is also available on Vimeo afterwards, and please do help also elevate the elevate that message so that it's clear that we need to also look at access and outcomes of care within our cities. So here's what I'm hoping I've been able to convince you on. That our new thinking is the need to recognize that urban and rural areas of the global south have unique problems, with IMOC geographical accessibility. And within urban settings, poorer people and those living in slums are the ones most affected. Okay, let's move on to the next new area. That is the methods of doing our assessments. And I've been involved in this way back since 2016 when I've been really exploring how were we assessing how women travel to get to care. It's been a range of methods. We've started as simple as just looking at what we call Euclidean distance. So as the crow flies in a straight line, you have a point A, you have a point B, you draw a straight line across and say, that is the journey that the woman took to care. But clearly, that's not how the woman went but we've used such approaches before. We've had the least cost surface pathway approach, which we've used for some time, this network distance. We've had this sort of gravity model. A lot of these methods, or all these methods, will tend to point you to the pathway that the woman had traveled to care, but doesn't necessarily tell you, it doesn't reflect the reality of the travel that the woman had gone to care. Now, you will recall that earlier in my presentation, I showed you the flag of Nigeria. So this is where it comes in. This paper, published by colleagues Uoma et al. And some of those on that paper are friends, Peter Macharia, back in 2018, was an attempt to look at the entire continent of Africa and get a sense of the travel that it took, that people take to get to the nearest hospital. And so everybody now on this call, we're all Nigerians now, I believe. Okay. Everyone now knows where Nigeria is here. Right. I do not need to point that out again, but just for emphasis sake, it's right here. Right. That's it. And when I saw this, I was like, something is wrong here. What this, it says, for those who are able to travel within 2 hours to the nearest facilities is all colored in green. And Nigeria was almost entirely green. And you look at the bottom right-hand side here, about 92% of Nigerians are able to get to a facility in 2 hours. Excuse me. I was like, no, that has to be the flag of Nigeria. That cannot be about the 2 hours travel, because that's not the Nigeria I know. That's certainly not my experience of living in the country. So what we quickly realized is the point that I just made earlier, that a lot of those models were not reflective of the reality of travel. But we wanted to actually show evidence of this. So what we did was we had actual journeys of women who traveled to care. And these were women who presented in an emergency. And in this paper, we compared the different methods that had been used previously to assessing travel time, this cost friction approach, similar to the least cost approach I mentioned earlier, the open street route mapping. And then we use Google Maps, right, which we were proposing as well. That's kind of something that we use regularly to look at where we're going to. And then we compare that with two independent drivers, drivers 1 and 2, who try to replicate the journeys that those women would have taken to care. And what you can see in this box and whisker plot as it is shown, this is the same group of women, right? These are journeys of the same women, just reporting them based on different methods. And you can see very clearly that those existing methods are nowhere close to the reality that this woman would have faced in trying to get to care. So I put a comment here to say, look, those traditional model-based approaches clearly do not reflect the reality of travel of pregnant women across African cities. Now, there's been some attempt to, scale up, those traditional approaches. WHO has been using this access mode, and with access mode, it's very similar to the traditional methods, but one thing that they do separately is to bring experts, as they call them, who are aware about the travel scenario within those different countries, to give a best guess estimate of how travel would look like. But they're not really experts. The traffic scenario in many of those cities fluctuates, even in the day, fluctuates in the morning versus afternoon versus evening. So these are very static maps that don't really reflect reality. And it was a huge challenge. So we thought, okay, like I said, let's use Google Maps. So we took Google and we applied it across the state. We started with Lagos first of all. Looked at the case notes of women who all presented in an emergency, over 5,000 plus women who presented on their own volition in an emergency, mapped where they started their journeys from, tried to recreate their journeys using Google Maps, and then pulled all those points, and I'll show this in my next slide here. Every single point you see on that map reflects the starting point of a woman's journey to care. And then the color gradient is what you see on the right, where you see red. Those are places where a woman would have needed to travel over an hour, sometimes 2 hours to get to care. So we were then able to pull all those 5,000 plus points together, and then where we see an aggregation of red dots, basically points to where women are having difficulty in getting to access care. Okay, so you can see one around this area here. You can see one here. We call them clusters. We call them hotspots. And we're able to find 4 main hotspots, which we were then able to pass to the state And that led to, I'm not sure if I have that on this slide. It led to a lot of policy change within the state, including building new facilities, optimizing existing ones to make sure that they can cover for 24 hours and so on. So literally, I think Google heard about this, and it led to the formation of the group that I call the On Time Consortium, which had been mentioned earlier on. On time meaning on tackling in-transit delays for mothers in emergency. And we had an initial conversation about this on how Google could support this. And I know everybody sometimes says Google is your best friend, but for me, I think Google is really my best friend because the organization has supported my research since then in trying to scale this approach up, but not also just doing it from a, almost like a retrospective lens where we have to look at case notes to extract where women start their journeys from, where they are referred to and where they go to, but also trying to do this from a more perspective to sort of develop a planning tool that policymakers can use to optimize access to emergency obstetric care. So that led to this development of this digital dashboard that we've done across 15 of the largest cities in Nigeria, where populations of over 1 million live, including Lagos, obviously. You can scan that QR code to take you to this digital dashboard. On that dashboard, it's linked to an API with Google, which then plots the travel time to access care. And policymakers can engage with this platform to get a better sense of what accessibility looks like, and then inform prioritization of areas that need to be fixed, or at least the next step, at least what we've done in some parts of the country, is to get a contextual understanding of why access is a problem in that area, and then come up with policy recommendations to fix those areas. Quickly, I'll just summarize some of the evidence we're able to gather from that dashboard. Obviously, we're able to get like travel time to care. And we know that a lot of the traditional tools are able to estimate travel time to the nearest facility only. But we know that women sometimes bypass the nearest facility to go to the next nearest or the next nearest because they have some preferences, whether it's in terms of how much it takes to the cost of services in specific facilities, or just the attitude of health workers in the nearest one. So we did want to incorporate that element of choice in whatever platform we were building, which you would see on the dashboard. So we looked at travel time, wanted to look at the percentage of women of childbearing age who are within 15, 30, and 60 minutes. And I'll talk about the importance of those different benchmarks in a minute. We wanted to get a sense of number of facilities that are reachable within those different time benchmarks for pregnant women also. And then again, just getting a sense of having a clear understanding that accessibility varies at different times of the day. We wanted to have different departure times during peak and non-peak periods. We wanted to do this across the entire city and then to each specific community, because we know that accessibility from different communities also vary. Okay, somewhere in there you see about public and private, just again incorporating that element of choice for women. This paper and key insights from that paper was published in a paper earlier in the year. Results from it were published in the Lancet Global Health in May 2024. I just briefly pull out some of the figures from that. Again, just showing that variation in accessibility for women who are trying to go to the nearest versus the second nearest to the third nearest, as well as the amount of time and number of facilities that women are able to get to within those different time periods. But as I mentioned a moment ago, we wanted to do this on a community basis, and these two charts side by side, looking at women who are within 30 minutes of the nearest public or private facility, shows how it can be varied and it can be stable, right? On the left side, you see a lot of variation from different communities throughout the day. And then on the right side, you see that for some communities to get to the to get to facilities, or there's not so much variation over time as the day progresses. We're also then able to combine this evidence in terms of travel time, link that to other data sets, for example, like relative wealth index. And one of the exciting things we're able to show here is how essentially the way our health systems have been designed, it's actually disadvantages people who are particularly poor. Consistently, as you can see on this chart, the poor people are able to, who are those represented in red and orange mostly, and then the wealthiest being the blue. We've set up health systems in Nigeria, at least certainly in the cities, to disadvantage the poor people. The red and the orange showing that they have to travel the longest to get to services. They have the least number of choices of services that they can, facilities that they can go to. So somehow, as I said, the system is set up to disadvantage them. So our new thinking in terms of what the future looks like is that when we are going to assess, in terms of how we assess geographical accessibility to IMOG, we need those tools to better reflect the realities of travel in specific settings. Now, access mode, as the WHO has been using, would work very well in rural areas where there's a lot of stability, but we need a lot of this more navigation-enabled mobile applications to support us in urban areas so that it can reflect the variation in accessibility at different times of the day. Now, I'm sure that as I've been speaking, many of you have been thinking of what might be some of those solutions that would work to address these issues that we've talked about today, right? And there are many of them, right? I'm just going to flag a few examples. Here is a cross-section of community-based first responders who are being trained, and the plan was to deploy them into the communities to then support people who need emergencies to travel to get to health facilities. This is the M-Mama scheme, which works in Tanzania. And you have an ambulance there trying to make it into a rural community. It's linked to a phone system and so on. You have the 108 number in India, which is a free-to-call telephone number emergency that you can use to call emergency services in India. I think it was established sometime in the early 2000s. And it helps to sort of ensure timely medical response and minimize those deaths. As of 2024, there are almost 11,000 of these sort of ambulances in the country. But again, here you can call that number and somebody picks up. In some places, not every ambulance system is like 108. For some places like Lagos, those ambulance systems will pick you up from a facility and take you to another facility. But you still have to sort of figure out how you get from your home to the first facility. There are a few private ambulances right now, but mostly that's how it looks like. Of course, one other solution would be to build more facilities, right? This is some facility that was built in Lagos also focused on maternal and child care alone. So mostly they will provide emergency obstetric care also in this building. However, there was some research done by Chabot et al., and their position that, look, this is essentially a white elephant project, right? It might come across as politically attractive, and I do have some videos of politicians, who are super excited to show that they are launching a new hospital, but it could also have a negative effect on the foundational primary care system if we're going to be depending on hospitals all through. Sometimes they are super expensive. It's not just about building the hospital. You have to think about the human resource to manage those hospitals and so on. So again, that's really reflect on whether building more is what we really need. UNFPA had talked about optimizing the existing ones. So rather than building new ones, let's see how we optimize existing ones. And so there's a whole implementation manual guide on how we implement, and develop a national network of emergency obstetric care services built based on a clear recognition that travel time to those services also really matters. So the new thinking here is that clearly it's not a case that one size fits all. I would argue that we need to probably consider care delivery systems that principally takes emergency obstetric care to pregnant women in rural areas and takes pregnant women to care in urban centers. And I think that sort of mixed match approach is probably what we need to be doing. So not everywhere needs an ambulance. Not everywhere needs a new hospital. Not everywhere needs roads fixed. Yeah, so certainly not a case of one size fits all. Now, this target is probably the last bit, of the fourth section that I wanted us to look at. And the WHO had several years, this was 2009 when this guideline was released. They had said then that we needed to ensure that women are within 2 to 3 hours of travel. I repeat, no, it wasn't women. Most women, I have to emphasize on most women, should be within 2 to 3 hours of travel to get emergency obstetric care. And this was deemed reasonable at the time. And in fact, afterwards, we've had a Lancet commission that referred to that most as being 80%. Like if we could get 80% of women to care, that would be fine. I've tried to inquire from everyone as much as I can, like what was the rationale for this 2 to 3 hour benchmark? Why was that the target? The best I've heard is that it takes about 2 hours for a woman who has PPH, postpartum hemorrhage now, to bleed to death. And that was the rationale for this. And you'll see the same benchmark repeated in the EPMM target, as it's called. I think I highlighted here that every pregnant woman with obstetric complication, now there's a global target of 60% to be able to get to care and 80% and national target and so on. So clearly, there are some 20% of women that, as far as WHO is saying, don't need to get to care, right? Or 60% when it comes to the global target. So the other 40%, how do they get to care? Why shouldn't they get to care within that time? And for me, most importantly, is how does that link to the so-called leave no one behind mantra that we've talked about severally? What happened? Why are all those other women, why shouldn't they be able to get to care in good time? And really, if you recall, I talked about that 2 hour benchmark being about bleeding to death for postpartum hemorrhage. That strikes me like that is the time to death and not the time for travel. And we've done research, and I would spend very little time on this, where we've shown the link between travel to care and maternal death, as well as travel to care and stillbirths. And we can see that just about 30 minutes of travel, inter-facility travel for pregnant women, anything more than that puts the woman at significantly higher risk odds of dying due to complications of pregnancy and childbirth. And journeys as more than 10 minutes for their babies mean that those babies have a higher chance of being born dead. So 2 hours is way too generous, time for us to be given for travel to care, considering the fact that she still has to look for, some women, they have to look for that means of travel and so on before they can get to care. So the new thinking we're pushing here is that we need context-specific, clinically relevant, and evidence-based benchmarks for emergency obstetric care geographical accessibility that clearly reflects the on-ground realities to move these things forward. So as I wrap up, the question is, what is needed for the future? I think that as we move into the future, this application of this new thinking, where we use what we are calling closer to reality travel time estimates for geographical accessibility to emergency obstetric care, will support evidence-based decision-making for health system redesign, which ultimately will guarantee value for money, help us address a lot of those inequities with more precision, and contributes to the realization of that universal health coverage that we all dream for and desire, and in the end, leads to improvements in maternal and perinatal outcomes. I am excited about some developments. I know that research that we have done, especially the one that I showed you on linking the travel time with maternal death is pushing the WHO to rethink the 2 to 3 hours benchmark. And I know more recently there's been some push for this a new benchmark of 30 minutes inter-facility travel time as part of the EMOC revisioning project, which is really exciting. And really looking forward to that becoming the mainstay and guidelines as we move things forward. For me, I firmly believe that not most, every pregnant woman in emergency should be able to travel safely and quickly to a functional health facility. It's only when we have done this that we would ensure that we have left no one behind. Thank you very much for your attention. Thank you.
Thank you so much for that very provocative and innovative, talk, Dr. Banke-Thomas. And I know that I'm just going to let the attendees know to feel free to put questions in the chat. I know we have one. I have a question, and then I'll get to Sarah's question as well. How easy or challenging has it been to work with, I know you're doing this across many different countries. I know you focused on Nigeria, but to get the government and kind of Ministry of Health support, or what are the challenges there to kind of continue this or use the platform? And I guess my follow-up is like, are they starting to use the platform, and what are they doing with the data that they're getting? Do we have any data on that yet?
Great question. Thanks a lot. Thank you so much, Dr. Deb. Thank you. So, yeah, so a lot of the decisions that inform how this sort of service planning is done is very political. It's very political. Some promises that have been made during the election. I will build a new hospital here, and that's it. But what we've done is that we had engaged with policymakers in Nigeria from the very beginning. As part of even the design of this project, there was strong engagement. In Lagos, for example, where we've had a huge impact of this work, the health commissioner in Lagos was part of the research team. And so as the evidence was being churned out, he was digesting it and coming up with strategies right away with the research team. In Edo State, which we just wrapped up what we call the Evidence for On-Time project. That was a knowledge translation project where we spent 6 months with 9 months with policymakers, and every 3 months we were reviewing the evidence from the dashboard with them, collecting contextual evidence to support that, and then coming up with priority action points for them to do. And that has really been a very, very impactful project on the ground. We're seeing changes in referral policies within the states because of evidence from this and so on. So yes, it's tough, but I think as researchers, we owe it to be able to communicate this evidence in a very simple, easily digestible manner to policymakers, to then ensure that they're able to get that the necessary policies and interventions being implemented.
Thank you, because I know we have a lot of attendees, some are faculty, we now have some students on here too. So I think for them to hear how important it is to engage policymakers, just like you need to engage the community from the very beginning and get their buy-in is so important in any kind of global health venture, I think. And along those lines, I know you said that, the needs of every city may vary in terms of whether they need ambulances or roads or hospitals. What have you found has been maybe the most common or significant need, or do you really think it's just variable across the board?
Yeah. I think we have to be careful with thinking of this, as I said, as a one-size-fits-all. Even though we know the WHO has a framework, for example, called the ECS framework, which is Emergency Care System Framework, which is there. So the different components are there. We know we need ambulances somewhere. Potentially we need some choppers maybe somewhere. We need some community-based responders somewhere. We know, but how we mix and match them is different in every city. And I think it's that combination of those different components of that intervention package that needs to be bespoke to cities. And so that's what we're trying to do, because ultimately this is about ensuring that there's value for money with what is spent. There's no point in building a hospital if it's not needed. There's no point in spending the same amount of money that could have been used, in just training community-based first responders in a particular area to using that to building a hospital. So it's that mix of the intervention components that we think this sort of very granular and specific evidence allows us to be able to develop with the support of policymakers.
Great, thank you. So Sarah Hutton put a question in the Q&A box here. She said she has a description there about how travel and access issues are dire in cities, and the situation is worse, as you said, because in a city, the assumption is that services are more accessible than rural areas. In reality, it is worse in cities than spots further west, referring to Kenya specifically, as she's not been to Nigeria. The lack of infrastructure, such as Majimoto getting into Loida Hills. And so her question is, what do you see as the role of telehealth services playing in emergency situations to advise, empower people in close proximity, and probably triaging to help these women during a crisis emergency when it's physically impossible to travel to a clinic?
Well, no, a fantastic question, Sarah. And I see you talking about Kibera. I'm not sure if you've been there before, but Kibera is crazy. I've been to Kibera before. Yeah, and even just trying to make it out of Kibera, just trying to make it out of Kibera can be very challenging. And so you're spot on, as we do have that opportunity to have sort of telemedicine to support this. The challenge in the context of which is one of the points I made at the beginning, is the care still has to be delivered in a health facility. And I know there's some heroic spouses that have delivered their wives of babies. I know some of them. But ultimately, what we don't want is to this cannot be. We can have a community specialist deliver the care at home to the woman to sort of support it. If it's difficult to get access, there are some places, for example, in Madagascar, where we know that travel is probably about 6 hours to the nearest facility, right? But trying to turn that into a telemedicine service, I think we'll need to sort of maybe explore that a bit more. We can obviously advise women, we can triage like you mentioned, Sarah, but I think ultimately we have to think about how she gets definitive care. And that's either, like I mentioned, taking the care to her where she is. So in a place like Kibera, maybe that's something that we need to look at, or getting the woman to a facility where they can provide that care. Thank you.
There's another question in the chat. Are there any specific political challenges that you've seen with respect to the implementation of new evidence-based policies?
All right. Yeah, Janina, thank you so much for that. Yeah, I mean, yes, these challenges are always there. I think I mentioned that very briefly, that, it's what it is. But we literally, my team and I think some of them are on this call, we date politicians with our evidence. We take it to them, we present it to them in a very engaging manner so that they see, which we're trying to let them say, this is the scale of the problem. And we're telling you that the best place for you to spend your money, no, not your money, the people's money, is right here and doing this because of this, or we co-develop these things, these interventions with them. And I think with that process, we're able to overcome such challenges. Right from the very beginning, you want to engage them. You don't want policymakers to hear about your research after it's published in the Lancet. You want them to hear about it before you submitted the proposal to the UMass ethics committee, and let them feel like they were a part of that conversation from the very beginning. I think if at all there's any challenge that I'm now worried about is in a particular state where we're working right now, the ruling party has changed. And I guess it's changing in America also. So changing is, then there are a couple of options. It's possible that the incoming party might not think what you were sharing with the other one in the previous party is of any importance, or they want importance somewhere else, or start their own interventions and so on. I think the approach remains the same. Prepare. We've now worked on preparing like a policy brief, bring that incoming government to say, hey, we had that summarizes key evidence that we think you would want to know about as you start your new government. But it is hard work. It is honestly, that's the only way to say, Janina, that it's hard work trying to get political powers to take research evidence serious. But it's something that we cannot stop doing. We just have to keep doing it.
Thank you. If anyone else has questions, please put them, I guess, in the chat or in the Q&A. I have another one. So my kind of parallel experience or exposure really has been with like telestroke in the US, being a neurologist, and I'm not a stroke neurologist, but just, hearing about it and kind of similar but different, access issues to stroke, although we use telestroke, which has really, boomed across the US, especially during the pandemic. But in terms of emergent OB access and care, do you know about similar challenges in the US or anything that's being done on a similar level in terms of using, the Google platform and trying to get at, because I'm sure there's similar issues here too.
Yeah, I've no great question. So yes, I mean, in a lot of rural America, this is access to emergency obstetric care remains a huge challenge. Myself and Professor Krista Johnson-Agbaku worked in Arizona previously trying to improve access for Somali refugee women. And this sort of platform would have been very helpful to map where access is a huge challenge and support those women or prioritize those areas to make sure that bespoke interventions can be addressed there. I know this specific technology was used by Arandne Labs in partnership with Google to identify what were called COVID vaccine hotspot deserts, COVID vaccine deserts, where there was obviously a challenge to motivate people to go get their vaccines during when the pandemic was a real thing. And so part of that mapping was to identify where the vaccination sites were initially, and then make sure that everybody could travel to a vaccine center, I think within about 30 minutes. And so those areas that they were desert, as they were called, were areas that were then prioritized using this sort of evidence. So I certainly see the applicability of this sort of closer to reality data, especially with the spread of machine learning right now and all the country, even in advanced cities, many cities across the US, where this sort of tool can be deployed to really optimize access to critical services, including the one you mentioned on stroke.
Well, I just want to thank you again so much for making the time. We're so honored that you're able to join. I know how jam-packed your schedule is with all the different initiatives that you're leading and all the impactful work that you're doing. We really appreciate, the opportunity to hear about your work and, to support it in any way we can and to kind of spread the word or be partners and collaborating where it's possible. So we really appreciate it.
I mean, I can see a question from Sarah, if it's okay. I see a question from
Oh,
Sarah.
sorry, I missed it. Yeah. Sorry. Yes, go ahead.
Yeah, about a bit on balancing the issues on safety, disclosing geo coordinates for services. Right. It's a brilliant question. Sorry, is it okay for me to take that question quickly?
Yes.
Yeah. So I think the safety, again, let's balance this up. So there is the geo coordinates for women, for example, where they're living, versus the geo coordinates for the service. We do want to know the geo coordinates for services and where they're available. We want to be as precise as possible on those ones because that's the critical bit. The geo coordinates for where people live, well, that's always displaced. So we've not actually mapped specifically where people live. We know from especially for women's health and social political. Yes. So we are not mapping specific women. You cannot identify one woman from the dashboard. What we've done is every single habitable spots on the land of every city has been mapped to the nearest, second nearest, and third nearest facility. So in Google's language, every single 600 by 600 meters is called an S2 cell. So if that place, people can live there, we map journeys from that location to the health facility. In any case, if you wanted to do this more retrospectively, you can always displace those points. This is an approach that DHS does, and we do that also when we do this retrospectively, to displace those points a little bit, so that you can precisely say where people are. But thank you so much, Sarah. That's a great question. Thanks. Sorry, back to you, Deb.
No, that was an excellent question. Thank you, Sarah. You bring up a really good, important point. No, so just, yeah, thank you again for joining, and we're so glad that you were able to join. And we have recorded this, so if you're okay with that, and you can let us know that we were going to share it with whoever is interested in watching it, who maybe could not attend or could not participate today. But we really appreciate you taking the time to be here, and it was wonderful meeting you.
You too. Thank you so much, Anindita. Thank you so much for everyone also for joining. Really appreciate it. Enjoy the rest of the day.
You too.
Thank you. Thank you. Bye-bye.
Bye.
Bye.